Okay, so here we go. Yes, good morning, friends. Sorry for the delay. Dr. Santosh had some difficulty in establishing the connection. Uh, to briefly introduce Dr. Santosh Kumar, he's professor at Sumandip Vidyapith Deemed University. He is a consultant audiologist and speech language pathologist, and is an alumnus of All India Institute of Speech and Hearing based in Mysore. He had his graduation, post-graduation, and PhD from Mysore University. His areas of expertise are adult language and voice disorders. And to his credit, he has more than 30 publications and 35 oral and poster presentations at national and international level. Today, he is going to talk about bridging the gap, integrating ASLPs, that is audiologist and speech language pathologists, into multidisciplinary clinical team. A very new subject for all of us. And we look forward to a very informative talk from you, Dr. Santosh. Please go ahead and start your presentation. Thank you for joining us.
Thank you, sir. Sorry for inconvenience. Okay. I will share my PPT.
Yeah, please say.
Is it visible?
Not yet, not yet. It shows that you have started your screen sharing, but we are seeing a blank space. Yes. Now we are able to see your slide. You can put it on slideshow so that we can see it full screen. Yes, yes. It's working well. Please go ahead.
Can I?
Yes, Arif, what did you want to say?
Yeah, I wanted to let Dr. Santosh Kumar know that I specifically joined for this one because one reason was I have tympanometry. We have two students of mine working on tympanometry, and tympanometry in allergic rhinitis and involvement is a very important thing. So if you could just enlighten us on that aspect also, it'll be very nice.
Okay. Dr. Santosh, Dr. Arif is an allergy specialist. While we were waiting for you to join, he was just talking about something new work that he has done and presented at International Forum. So please go ahead now.
Okay. Thank you, sir. So myself, Dr. Santosh Kumar, and I am professor at the Department of Audiology and Speech Language Pathology and working at Sumandip Vidyapith, Kim to be University, Vadodara. So today's topic is actually new, and many of us, we don't know what is the role of ASL, is audiologist and a speech language pathologist. Some people says that it is in Hindi they say gunge behre ka doctor, but it is not like gunge behre ka doctor. So we have entirely different things than the gunge behre ka doctor. That is a different person dealing with. So audiologist and speech language pathologist means audiology means hearing related to hearing. Speech language pathologist means speech, what we produce the sound, what we speak. Related to that, if any pathological condition, if any disorder is there, any problem or any issues are there, that we are rectifying. So this is the department. So who are audiologists and or speech language pathologists? So the course, the science background student can do the course like diploma in speech hearing, language speech. Bachelor degree they can do like BSLP, master degree in audiology, master in language pathology, then PhD in audiology and PhD in SLP they can do. So here is the difference is like if they do the diploma is only 1 year course. So they will be only assisting the audiologist, like who has done the BSLP or above that degree. So they will be posted as the technician, diploma student. And then after doing the BSLP degree course, audiologists and speech language pathologists are eligible to open their own clinic. They can work independent. So the bachelor degree They can work as an audiologist and a speech language pathologist both, as a both. But when they will do the master in that a specialized area like audiology and speech language pathology, they will go through that at a specific area, like in audiology or speech language pathology. And if they do the PhD and all, they will more related to the research. So BSLP, MSc, or PhD, they will be either BSLP will be audiologist and speech language pathologist both. They will work for both areas. And after MSc, they will become the either audiologist or the speech language pathologist. And the research they will do. So these courses are affiliated from the Rehabilitation Council of India, RCI, New Delhi. So they give the approval for the course, then only university can start this course and they can train the audiologist and speech language pathologist. After finishing the degree or DHLS, MSc, they will provide a license. They will provide a number like MCI, how they will give the license number. Like that, RCI also gives the number to work independently, to open the clinics independently. We can work in hospitals, schools, and other places, but we can open our own clinic also. They provide us the license. So SLP is the role is like early identification, evaluation, and rehabilitation of speech, language, communication, hearing, balancing, and feeding difficulties for pediatric, adults, and genetic population. So here it's like we have to identify early, evaluate the assessment, and then rehabilitate them. So whatever problem related to speech, language, communication, hearing, balancing, and feeding, we are dealing with. So after doing the degree course, I hope that then we work as a clinicians, teachers, and researchers. Our role, it is there in the like disability certification authority in the field. So if the person is having a hearing loss or a speech language problem, we are calculating percentage of disability, hearing disability or speech language disability. So we have some formula for that, and with that we calculate the disability and we say that how much disability having the person. So what is speech? People say that like sometimes okay, speech and language is same. It is not same. It's developed hands in hand. Together is developed. But speech is like what we vocalize, what we say, what we produce sound. It is speech. But the language is the system of sounds and writing that human beings use to express their thoughts, ideas, and feelings. It may be verbal, it may be non-verbal. So both can be the language. So communication. So after speech and language develops, then communication can be done. So the act of sharing or exchanging information, ideas, or feelings. So if you exchange your ideas and feelings, it means communication is done. Means if you are saying something, person is say something and listener understand and responses to the questions, then it means communication is done. So here is the different types of communication. It's verbal communication, non-verbal communication, written communication, visual communication, and listening communication. So they are the different communication types. So soloing, how we deal is soloing has different phases like writing, preparing the ballers, and then soloing. So these are the phases they will have difficulty in that. So they will have the soloing difficulty. Hearing, they will not able to hear or they will have some problem in the ear. Balancing, vertigo problem may be there. So those people also we deal. First, we will move with the audiology, and then I will explain with the speech language pathologist work. So audiology, what they do, they provide comprehensive diagnostic and treatment services for auditory, vestibular, and related impairments. So here, whatever related to the ear has three parts: external ear, middle ear, inner ear, and the auditory nerve to the brain. So in that any issues comes, we will we will do the assessment, we'll find out where is the problem, and we give the treatment according to that. So we provide the services for persons with cochlear implant also. The candidacy of cochlear implant, if child has a problem with hearing, then we'll see the if it is fitting in the criteria of cochlear implant or not. After selecting the candidacy, patient has to go to the ENT and they will do the surgery. They will put the hearing aid and not hearing cochlear implant through the surgery, and then after that the audiologist role comes with the mapping, like electrode is fitted properly or not, and then that machine is working properly or not, and then after 1 month it will get switched on, and the person, the patient can start using the cochlear implant in usual. So overall, it is like optimizing and enhancing the communication. If hearing problem is there, you will not able to talk verbal. You have to use gestures and other mode of communication. So overall, if you see, then what is the role of audiologist is to improve the quality of life. Even a speech language pathologist is improving the quality of life through the communication today. So what are the activities or role of professionals of audiologists? So we do the prevention. So prevention, how it is done? So prevention is like promotion of hearing wellness, protection of hearing function, and noise measurements of acoustic environment. So for this, we do this camp. We go to the schools, different villages, and we teach them, we aware them about the hearing and how to take care of the hearing, how to take care of ear, how to keep hygiene of your ear. So like that, it will be get benefited. People will know that how to keep safe the ear. Like different departments people, we are awareing them about the ear hygiene and about the speech and language skills. Sound level meter is the measurement of noise. So we check the different places like industrial area, school classrooms, that how much noise is present in that room. It is acceptable or not. Like if noisy area is there, child will not understand the teacher's voice. So child will have difficulty. Sometimes what happens, child will be sitting behind back of the bench, so it will be very far. So child will have mild hearing loss, then mild or moderate hearing loss. Then it will be difficulty for hearing the teacher's voice. So he may not respond properly, or his academic may become disturbed. So after the prevention, that is the prevention measure, then we identify. So we go to the different schools, different special schools, old age home, in the villages, and do the camp. In that camp, we do the screening. Through screening, we are trying to identify how many people have the hearing loss or hearing problem. So many people will not come to hospital if they have mild or moderate problem. So what happens? They will be sitting. They will tell that okay, no, now it is काम चलता है. So like that, they will not go to hospital. So we are trying to reach to the needy people and trying to identify the problem and try to solve it. So maximum like schools and all, we covering nearby schools and villages, and we are going to old age home and India special schools and doing the screening. And if I get we get any proposal from any place that they wanted to hearing screening, so we conduct a camp there. So screening for speech language cognitive communication disorders and preferred communication modalities that may affect education, health, or development or communication. So that we have identified, and we are trying to do the screening for at-risk people, because what happened at the villages, they will take bath in the pond and they will not keep ear block anything. The water, the pond water will go inside to the ear and it will make the infection. So like that, we have to teach them, aware them how they can prevent the ear problem. Balancing impairment, then tinnitus. Some people have tinnitus, like sound will come in the ear without any stimulation, without any other places. It will come inside the ear. So due to this tinnitus, people get irritated, or it will disturb the sleep also. It will disturb the daily life activities. So these are the things which makes the problem the people. So we try to identify this tinnitus and all, and then we rectify. So other auditory dysfunction, if they have, that also we are trying to identify. So for such thing, we go to the other different places, we do the camp and get the data, and if it is getting solved there only, so we will counsel there. Otherwise, what we are telling, we are asking them to come to the department, come to the hospital, we will do the detailed evaluation. And after detailed evaluation, we are, so this is the old age home, they did the camp. Then we are doing the assessment. That was the screening part, identifying. And then the assessment is like, we are assessing the hearing, auditory function, balance, and related disorders, measurement and interpretation. We are doing the different tests and interpreting that how much is the hearing problem is present. And any problem with that, then we will do the management and contingency for person with hearing loss or cochlear implant. Then we, if it is required for the referral, we refer to the different professionals. Like this is the test where this is a PTA. Usually it is done in 2-room setup. We keep the headphones on the ear and we'll give the stimulus from the one side, and other side the patient is sitting, and they will respond with the patient response button, or they can raise their hand. Like in the second picture, you can see that the child is responding. Here is the conditioning we do. Like we present the stimulus, we'll ask them to keep the block, take the block, like that. So in that, different behavioral measurements are also there, like VOA, VRA, speech audiometry. Next is a special test. Here we identify where is the problem. It is like cochlear problem or retrocochlear problem. So sensory problem or neural problem, like that we are identifying in this special test. The other test is tympanometry. So tympanometry gives the idea about middle ear pathology. If it is any problem in middle ear pathology, the tympanometry will tell us that it is present or not. And if some people have the extension to function problem, then that also is available in this audio impedance. The newborn hearing screening. This is the main thing where with the first day of child, we can identify that the child has the hearing loss or not. We can say that the child is having at risk or not. So what we do here is we are doing the autoacoustic emission. We just put a probe in the child's ear, and the machine will tell us that it is pass or fail, a screening machine. So if it is fail, means child has some issues. It is not like it has the problem, but it may be problem. So we will call at 3 months. First day only we can identify, but the 3 months we take the time, because the first day sometimes what happened due to some other reason, machine tells the referral. Okay. So usually we can identify as at risk for babies at the first day of their life. Next is those people who is not able to respond in behavior tests like PTA and all, they can sleep down here and we'll put the electrode and it will be measured by the BERA. It is also called ABR or BERA, Brain Stem Evoked Response Audiometry. Here, patient has to sleep. We'll put the electrode, we'll put the probe, and we'll give the stimulus, and it will be measured. Here, patient doesn't have to respond anything. One more test is ASSR, auditory state response audiometry. Here, with the specific frequency, we can measure the hearing level. Then vestibular test, CVAM, OVAM, we can do, and we can identify where is the reason in the balancing problem. If it is balancing problem, is then after assessment we move to the rehabilitation. So it's like we have to select fits and dispense hearing assisted technology devices. Like if person has hearing loss, then we provide the cochlear hearing aid. And then if it is more problem is there, then we can see the candidacy of cochlear implant or other assistive listening devices we can refer. And then after fitting this, we have to consult to the caregivers also to take care of these machines or these amplification devices. And consultation and provision of vestibular and balance rehabilitation therapy to person with vestibular and balance impairment. If they have problem, we are giving the different. We are using the different techniques. We'll teach them, and they have to do that. So assessment and non-medical management of tinnitus using biofeedback, behavior management, masking, hearing aids, education, and counseling for the treatment of tinnitus. Like hearing aid, you can see the put the here in this picture, we have put the hearing aid on the ear level, and then we are programming and we are asking some question. We are communicating with the person and asking them how it is comfortable and how much he is going to respond. So which hearing aid is proper, we are checking that, and then only we. After giving the hearing aid, sometimes it don't fit properly in the ear, so we provide the ear mold. We take the shape of the ear and we put it with the hearing aid. Then this is the tinnitus retaining program, retaining therapy, and here we are seeing the matching assessment. How we are doing that? Which is high or low? We see the pitch and the loudness matching. How much is coming? We don't know how much tinnitus is present in the patient. So we ask them, we give the stimulus, and we ask them which is low, which is high, and how it is differ. So we will match according to that, and according to that, rehabilitation is done. Auditory verbal therapy, we give to the who has put the cochlear implant. This child is cochlear implant child. We have the cochlear, after cochlear implant done, we start the auditory verbal therapy. We use this verbal therapy because we have given the amplification hearing, so that we try to improve verbal communication. Then other thing is measurement of noise we can do. Moving to the next part is the speech language pathology. So speech language pathology, in this, the speech language pathology is also to the clinical services, prevention, advocacy, education, administration, and research in the area of communication and solving. So overall, what we are doing is that improving the quality of life. So speech language pathologist addresses typical and atypical communication and solving in the following areas. So what happens if a child is normal but child may not speak? So what happens sometimes due to they don't have any anatomical or functional problem, but child is not speaking, but he is comprehending well. So in that, stimulation is required, because due to lack of stimulation, child is not speaking. Sometimes what happens nowadays, like okay, 10 o'clock I should get the food, 11 o'clock I should get the bath. Okay, so parents are giving all things on time, so child doesn't require to speak anything. So what happens? They don't require to speak because all things are coming to them. Like we are working. Why? We want money. We have to work. Then only we will get the things done. If everything comes by their own, then we will not work. Like that, the condition with the child. So in that condition, we give the stimulation. We use some different technique, and stimulation we give, and then child will become, child will start speaking. It takes some time depending on the child's cooperation, but child will become not. So these are the different areas where this is like speech disorder, language disorder, social communication disorder, cognitive communication disorders, and sawline disorders. SLP work in these areas. So what are the different types of disorders? So different types of language disorder will be there, like autism spectrum disorder, ADHD, hyperactivity, HI, hearing impairment, Down syndrome, IT, intellectual disability, learning disability. We deal with this kind of patient. And then other language, what happened? Aphasia will occur, neurological disorder, like after a stroke, patient will not able to comprehend or not able to speak. So that time it problems happen. I'm not able to speak. So cognition problem also, if it is there, then we deal with them, and the feeding and swallowing. Other clinical population is like fluency, stuttering, cluttering problem, like haklana. So they will like mera. In this condition, we give the techniques and resolve it. Each problem, like boys is speaking in like male is speaking in female's voice and female is speaking in male's voice. So pitch loudness quality or hyper or hyponasality will be present. Those cases we deal with. Swallowing difficulties, child and adult, if they have any swallowing difficulty, chewing difficulty, we can treat them. So head and neck cancer people will have the speaking problem. We teach them. Speech sound production, like articulation, apraxia of speech dysarthria, they will not able to produce proper sound like pa, ka, ma, whatever. They will do the substitution, or their sound quality will not, intelligibility will not be proper. So that also we did. So clinical services of SLPs is like prevention, screening, assessment, diagnosis, treatment, counseling, collaboration with other departments, documentation, and then letter. So this is the way we do the diagnosis, like we are asking, communicating with the child and getting the information, how much child is level. We will ask the parents, but still we have to mingle with the child and see how much is the level of comprehension and expression. Then this is the voice analysis. Voice analysis, here we have the instrument like MDVP. In this instrument, we like patient has to say phonation, e and u. Three things we use is, and then based on that, the voice, the instrument will tell the patient voice is proper or not proper. Like pitch is abnormal or the loudness is abnormal. Different parameters are there. So based on that, rehabilitation is we are doing. Here, this is the instrument WAGMI. In that, nasometry is there. Here, we have to keep it, this instrument near the nose and the mouth. Between that, we have to keep it. And two mics are there. They will measure how much sound is coming from nose and how much sound is coming from the port. So we give the stimulus to read that in that nasal sound and oral sound. Both will be there. And the percentage we see in the instrument, and it will be based on that, we will identify it is a hyponasality or hypernasality. This is the electrography. And we put the electrode on the larynx, that is thyroid characterized lamina, and there we'll put and ask the patient to say or. So in that we will see the in the machine that how vocal cord is functioning. If any problem is there, then we give the technique to different treatment. The SLP can use the stroboscopy also, but it is very rarely available in the institute. Sometimes it is not available also. But if those SLPs who is trained in stroboscopy, they can use that. Speech language therapy, after the getting diagnosed with the problem is like a comprehension or expression problem, we give the therapy. Then here, voice therapy, same instrument we can use. Then if verbal communication is not done, not happening, not improving in the verbal, then we can go to the AAC, that is augmentative and alternative communication. So in through this, we can teach, they can just point out or they can select this visual pictures or words, they can frame the sentence and they can communicate with other person. Then advocacy and consultants, we like audiologist and speech language pathologist is doing the work like funding of services for those with hearing loss, auditory or vestibular disorders, speech and language disorders. We tell them from where you will get the fund and how they get benefited. Some people will not be able to purchase the hearing aid or cochlear implant, and so we tell them how to go through. And government policies are there. They give the ADP scheme. Through that they can go and they can get the benefit. So issues related to any hearing and communication disorder and consultation with other professionals, which it is required, we are doing that. So like individual, public, private agencies and government bodies, we work as expert witness regarding legal interpretation of communication disorders. We also go to the industry and tell that how much noise is required, how much permissible noise where the people can work. Like that only our education, administration and research we are doing, like educating the public, educating the providing in service training to families, caregivers, administrating and managing clinical and academic programs, developing policies and professional standards, and conducting basic and applied research related to the communication science and disorders, balancing and solving. So practicing like SLP where they can work. They can work in public and private schools, early intervention settings, preschools, daycare centers, healthcare settings like hospitals, medical rehabilitation facilities, home health agencies, NGOs, clinics, new natal and intensive care units, behavioral mental health facilities, private practice setting we can do, individuals, homes and community residents, corporate and industrial settings. So what is SLP's market trends and future outlook? So it's like audiologists and speech language pathologists are in high demands across the globe. So audiology ranked at number 11 and speech language pathologist at number 25 in the analysis. Like this is the ASA has given, American Speech and Hearing Association did the study and they gave like this ranks. And audiologist annual salary averages around $70,000 according to the survey, and a speech language pathologist is like it's $65,000 per annum. And according to the survey, it's like employment rate expected to increase by 34% within 10 years, which is faster than average of other professionals. That's why the difficulty in getting in India these audiologists and speech language pathologists. If they do the master degree, they will rarely they are saying in India they will go to the abroad. And this audiologist and speech language pathologist work with the different multidisciplinary team like medical, paramedical, allied, and rehabilitation sciences. So this is Ajit Chittis. He has visited our department and gave good feedback to us. Thank you. If any questions or any queries there, I can.
So thank you, Dr. Santosh Kumar. You can stop the screen sharing now, so we can have some discussion. Yes, it was very informative. Actually, you gave a lot of information about what are the scope of ASLPs actually, and then their career option also you mentioned as. So are you running some training courses, like you are running some diploma course or degree course?
Yes, Sumandeep, we are not running diploma course. We are running BSLP, MSc in audiology, MSc in speech language pathology, PhD in audiology, and PhD in speech language pathology. We don't have DHLS.
Okay. And you talked about US market. How is the situation in India? Like people are aware about using your services, or you think that you are underutilized?
Yes, sir. It is aware, but not that much. Up to mark, it is not there, sir.
Hmm.
People are not taking admission also. Sometimes what happens, like so many institute, our institute is filled, seats are filled, but other institute is seats are vacant. This course is very much in demand, but people will not take it as like, it's a good education.
So you showed a lot of services which we are not aware about in terms of audiometry. Also, you mentioned a lot of other techniques other than the routine 2-3 things which we pediatricians know. So, what is the volume of your work? Like, are you getting enough number of patients to, give these services?
Yes, we are getting now, but still we required, we can handle more patient. If it comes, we can do.
Right. Do you collaborate with some institutes like private hospitals also?
Yes, sir, we are trying to do the MOUs, and we have done around 7 MOUs with the special schools, hospitals, and all. We are still communicating with other hospitals and trying to do the internship placement, or the after that placement also. Like if they can keep the student, they want, if they can keep.
Jagdish Bhai, are you there? You can comment on these kind of services which are provided at KGP Children Hospital and how it can be further enhanced.
Sorry, sir.
No, I'm talking to Dr. Jagdish Bhai, who is
Yes.
main person at KGP Children Hospital as Secretary of the Medical Care Center Trust, and he's a visionary. So I was just asking for his comments on this area of work.
I saw half of the presentation because I had to attend something.
Okay.
But some of the gadgets which he has showed later on, we do not have. We have for speech therapists working with us.
Okay, sir.
But some of the equipments and instruments which he has shown, as of now, we don't have. So I will have to discuss with him its usefulness and whether we should have it to give a better service.
Yes, sir. Sir, some instruments, these instruments are very costly. Nobody will get in the clinic. They will get in the institute. So these are the instruments. We are running the institute. We required for the training purpose, research purpose. That's why we are
Okay.
So KGP Children Hospital is also a big institute. That is why I was pointing out that there can be some collaboration.
If anything it is, then we will collaborate with them or with you, sir. No problem.
I'm raising this issue, Dr. Santosh, because there are often confusions and diagnostic dilemmas regarding hearing loss. I have seen at least 2 patients who were advised cochlear implants by 2-3 ENTs as well as audiologists, and then they came across a center where they were provided with hearing aids, and they are almost normal, like they have developed their speech also well. So these kind of dilemmas are there, and what I saw in your presentation is about fine tuning of these diagnostics also.
Yes, sir.
The kids are the most affected population as far as hearing is concerned. And across the country, we have a movement for neonatal hearing screening, especially in southern states like Kerala. But somehow it has not picked up so well in our state. People don't recommend, we pediatricians don't recommend every newborn should be screened for hearing with OAE at least. That is also not happening. I mean, the awareness is not there, and probably the resources are also not there. Like say in Baroda, how many centers offer OAE? That is also a question. So since you are so much deep into the subject, I would request you to start collaborating with say IAP, Indian Academy of Pediatrics, start a movement for awareness about this. And so if the screening is easily available, people would be happy to refer the patients. If they are available at few centers, then it may not work out that way.
We
Next
routinely do
week.
at
Sir,
KGPCH.
KGP, you have OA, sir, screening newborns?
Yes, we routinely do at
You routinely do to
KGPCH.
any patient, I mean outside patients also who are referred?
Yes, the outside patient
Okay.
from SSD, they are referred to us.
But
and
usually at
we-
KGPCH, the rush is much and maybe the waiting time is
No.
more, as I understand.
No. We
Your
routinely
voice
do
is
for
not-
SSDs referred patients.
Okay,
Free also.
okay, good to know that.
Hmm.
So what I would suggest, Dr. Santosh, that you can have similar kind of talk to, pediatric colleagues, pediatrician colleagues at one of our meetings where we have a clinical meeting every month or
Okay.
Thursday. So you can come and give similar talk to us.
Yes, sir.
Any other
I
comment?
can.
Dr. Arif had one question. Yes, Dr. Arif.
Yeah, Dr. Satish, see, in US now OAE screening has become a routine in Hyderabad. Okay, in most of the corporate hospitals and most of the maternity homes are doing it routinely. But in US, you see, every child who comes to the pediatric clinic has a handheld tympanometry done to look for middle ear effusion, especially in the first 2-3 years of life. I think that is what we should also.
Somebody is, let me see who is. Okay, go ahead.
Yeah. So have it in the US is a routine thing. In the first 2-3 years of life, they have a tympanometry being done to look for middle ear effusion, and we see a lot of children with allergic rhinitis or just non-allergic rhinitis having a middle ear effusion, and that is one of the important causes for gibberish type of speech or altered speech and for behavioral problems. So that's what I wanted to, whether they are doing anything for promoting tympanometry in pediatric clinics, outpatient clinics, to look for middle ear effusion. That is my point.
Yes, sir. This we have before here also it was not there. When we started this course and all, we have come and we started all things like OAs we are doing now. We will start through the whichever case is fail in the OAs, we are doing the ABR also. That is beta test, so that we can identify really the child has the problem in the hearing only. So that if we identify early, we can recommend rehabilitation. We can start early, so that communication will be normal. So like that only how US is doing that. Like that only we are following the pattern here. We are going and discussing with the ENTs, pediatrician, even neurologist, oncologist. We are going to different departments and giving our areas of interest and asking them to refer the cases for that. And if possible, we are going for the bedside evaluation.
Sir, the referral will come. Sir, the referral will come if the screening is done at their level. So that we have to start screening through this tympanometry and OE at birth. So just referring, all the referrals come if we start screening. That's the most important thing.
That's why we are going to the department like gynecologist department, pediatric department. From there, patient, one day child, we are doing the screening and getting the referral.
I think the point Dr. Arif is trying to make is regarding us pediatricians also, that awareness amongst the pediatrician about existence of allergic and other rhinitis causing middle ear effusion, I think is lacking, and there we need more integration of services. I think the basic aim of your today's talk was bridging the gap of integration. So I think it's a teamwork which will work based in the interest of the child. So thank you, Dr. Arif, for your comments. Thank you, Jagdish Bhai, for your comments. There are no more comments or questions. We can end the session. Any other question? No. So thank you, Dr. Santosh, once again. It was really very informative talk, and we will carry forward in this direction with collaborations, right? So thank you so much. Thank you all for joining. We meet